Hello, I'm Justin Kirk-Bailey. I'm a consultant intensivist and anaesthetist. I'm the fluid lead at my trust. I was awarded that position after I threw a bag of salty crisps in the face of my medical director one day. I also have been known to do a bit of ultrasound. I've got some declarations. I have received an honorarium from Baxter for providing education about fluid use, and I'm also going to advocate perhaps increased use of vasopressors, and I've undertaken consulting work for Synthetica, who make a ready-to-use noradrenaline preparation. We promised on the title to say why, who, and how. Well, why, Ash and Johnny may well have convinced you a bit about why on the basis of basic science and research. I'm going to point you in the direction of other people who think it's also time to change. More reasons why, and have done for a while. What about who? Well, you've got three fluid champions here. All three of us have been known to opine on social media and other platforms and share ideas with others and ourselves. But if you want to be a fluid champion, and we're hoping by joining us today you either already are or seriously contemplating it, I'll talk to you about how you might want to have other people fighting your corner and who they are. And how, what are you going to do to turn that tide, to switch from saline, to appeal to those hearts and minds and to elicit change? What steps you might take and what actually needs to happen. Now, I'm not preaching from a pedestal of perfect success, but I've spoken to a lot of people at various stages along the way of this journey, and I can distill some sage advice from them that I offer to you. I don't remember being taught much about IV fluids as a medical student. Jokes about not remembering much about my time at university we'll put aside, but I do know now that for years after graduating, I was getting it wrong. I wasn't alone. I don't really remember any practice-changing educational subject as a doctor in training either, certainly nothing substantial before entering anaesthesia and critical care, and I was a bit late to that. But I also know that even in anaesthesia and critical care, we're still doing it wrong. So forgive me and forgive everybody else. Quite often, the quick fix answer is just to give some more fluid. Actually, as you've seen, actually does more long-term harm than good. And the reason for that is that we're all guilty of it because it's just easy to do. And the alternatives that may be better for patients may be fraught with obstacles. There may be inertia, so we take a path of least resistance. More on that later. Anyway, we have a problem. Isn't usually one of dryness. It's time to fix that. This, if you will, from the three of us is a call to arms. The grass is definitely greener on the other side, even if there is less water. Let's go back to 1999. Back then, we had the National Confidential Inquiry into Perioperative Deaths, NCPOD. They highlighted that a significant number of hospitalized patients were dying as a result of infusion of too much or too little fluid. Whoa, let's think about that. 20 years ago, doctors were giving too much or too little intravenous fluid, and they were kind of effectively killing patients as a result. Oh, that's okay. We've taken note, haven't we? The end. We've stopped doing that, and patients aren't coming to harm. That was 20 years ago. Okay, well, this is one of my favorite slides. This isn't my own. I've been given this by Ash, and this is my favorite example of how practice has not evolved. This is a patient who has received 10 litres of salty water and been given for hypotension associated with pancreatitis. I think there's only one place management like this should go to, as I shall show you, because we've got 10 litres of salty water given over a relatively short amount of time. They realise there may be a problem, bit of pulmonary edema, some furosemide is contemplated, but actually that's not going to cut it, so they deliver some GTN infusion. But actually, obviously, that edema, that left ventricular overload has caused problems all of its own, and now we're into the realms of atrial fibrillation and amiodarone. Probably all quite preventable. Yeah, well, management like that should go to the box of shame. So let's talk about who else then, as I said, thinks that we should be doing things differently. This was the first document I came across that gave some detailed advice about what to do about fluids in patients. It got updated a bit in 2011 after issues with Hurricane Bolt with colloids. That's research fraud for those that don't know. But the message was unchanged. And although it's aimed at surgical patients, it makes a lot of sense and could easily be generalized to the wider ill population for patients. It was created in response to concern about the high incidence of postoperative sodium and water overload, and evidence to suggest that preventing or treating this by more accurate fluid therapy would improve outcomes. There are 28 recommendations with evidence grading, but I've begun with 4 here. If you're interested in reading it, this QR code that you can zap with a phone will take you to it. All of these are shown at level 1B, Those are individual randomized controlled trials with narrow confidence intervals. So balanced salt solutions should replace 0.9% or normal, abnormal saline, except in vomiting or gastric drainage. Dextrose-containing solutions are not for resuscitation. Many places have removed dextrose saline, 4% dextrose with 0.18% sodium chloride, from formularies after harms have come to patients because the rates given to patients were too high and caused mainly significant hyponatremias that led to problems with patients. Certainly that happened before I arrived in my hospital 10 years ago. And for maintenance solutions with water, sodium and potassium in adequate amounts should be given and monitored. And dextrose-containing solutions are for managing maintenance fluid requirements in patients with no other source of input and at a rate that matches physiological requirements. That's all they're for. And maintenance fluids should be sodium poor and have enough low sodium volume. Sorry, beg your pardon. Maintenance fluids should be sodium poor and of low enough volume until the patient has returned their sodium and fluid balance over the perioperative period to 0. Whoa, that sounds good. I've never been there, but the brochure looks nice. So yeah, back to 0. And I appreciate I work mostly in intensive care, anesthesia, but I do get out and about as part of outreach, and I do see quite a lot of edematous patients. And although this was targeted at surgical patients, don't you think that unless clearly dehydrated at presentation, this should be a target for everyone we look after? I think so. So maintenance fluid should be sodium poor, low enough volume until the patient returns sodium and fluid balance back to 0. Okay. So thinking then about everyone in hospital, NICE released some guidelines, some suggestions in 2013, a few years later, NICE CG 174. They said that you should assess and manage patients' fluid and electrolyte needs as part of every ward review. So you may look at their OBS, their TPR, listen to the heart and lungs, but actually you should look on the drug chart, etc., fluid and electrolytes, what they need, what they're getting. Should be done by skilled and competent healthcare professionals who should be prescribing and administering fluids. That's the people who are listening to me now. They're the people that should be doing it. Should offer IV fluid therapy as part of a protocol. They even went as far as providing a really helpful example of a templated fluid protocol. Do you have one in your hospital? Do you have this one? Do you have something similar? It guides between the use of fluids between resuscitation and maintenance fluids, and it even specifies the daily glucose and electrolyte needs, just in case you weren't sure. So it should be clear what a patient needs each day. So they said that patients should have an IV fluid management plan drawn up for them, that the weight should be measured twice weekly. So the best way to know what's going on with IV fluids is to have a plan, and the plan should include weighing patients. Well, it can be tricky in intensive care, but by no means impossible. Some of the more expensive beds can do this, but it can be incorporated as part of physical rehabilitation too, mobilizing from bed to the weighing chair and the like. If patients received IV fluids containing chloride, concentrations greater than 120 millimoles per litre, monitor their serum chloride concentration daily. So daily chloride. For anyone having anything pretty much other than a dextrose solution, do you have chloride as part of your use needs panel, or is it something you can add? That way there'd be no inexplicable acidosis from unmeasured chloride. And clear incidents of fluid mismanagement should be reported through standard critical incident reporting. Some of the people here may already be fluid champions. Ideally, then, incidents should report to you. For example, unnecessarily prolonged dehydration or inadvertent fluid overload due to IV fluid therapy. It should go somewhere in the hope that we can do something about it. But these are just guidelines, so what do we do with them? This. So the following year, NICE put out some standards, some quality standards. But they aren't mandatory, but they set out high priority areas for improvement and then define care areas. So they should be prioritized and they should be concise and they should be measurable. Why did NICE set out a quality standard? The reason for that is this. Well, in recognition that there are lots of errors in prescribing IV fluids and electrolytes, particularly in emergency departments, acute admission units, and general medical surgical wards. Theatres and ITU seemed to be okay when they looked. So people there, us, should be able to help everyone else then get it better. So let's be fluid champions in this speciality. In preparing the standard, they also noted that staff who prescribe IV fluids just don't know the likely fluid and electrolyte needs of individual patients, nor the specific composition of the many choices of IV fluids available to them. And I've had an ethnographic survey in my hospital, and from consultants to trainees to pharmacists to senior nurses to junior nurses, the knowledge about these compositions and the needs are woefully poor. So it's not one group individually. This is also, for me, the key message that comes out of this set of standards, and that is that fluids are drugs. The report recommended that fluid prescribing should be given the same status as drug prescribing. And that has consequences. The consequences that probably aren't taken as seriously as they should be in hospitals. People seem to forget this fact. It makes sense that they're seen as drugs. They have a dose, they alter physiological function, and we seek a desirable, measurable effect. Just on the bags here, it says prescription-only medicine. Prescription only, so somebody in authority prescribes it, and it's a medicine. If we withheld a patient their anti-Parkinson's medications for a week, we'd be in trouble. If we gave a patient 10 grams of paracetamol a day, we'd be in trouble. Yet equivalent fluid misdemeanors seem to go unchecked. Okay, back to the standard. So, hospitals should have an intravenous fluids lead. Do you know who yours is? I'm mine. Ash is his. Johnny's his. Every hospital should have one. Maybe from tomorrow, there may be a lot more. Adults receiving IV fluid are cared for by professionals competent in assessing fluid and their electrolyte needs, prescribing and administering IV fluids and monitoring response. So that's education then, isn't it? So we need to get messages out there so that people can actually work out what's going on with patients and what should be done about it. And having systems in place as well that we can monitor them. So those chlorides and things like that, those weights, those really accurately measured fluid charts, not just on the toilet, but having a really good idea of how much fluid is being excreted by patients and what we should be doing as a result by whichever route. Adults receiving IV fluid therapy in hospital have an IV management plan. The plan is determined and reviewed by an expert, which includes the fluid electrolyte prescription over the next 24 hours and arrangements for assessing the patients and monitoring their plan. And critical incidents that get investigated and steps are taken to ensure that they aren't repeated. So that's one way then to ensure that we can do stuff. Okay, all right. Well, look, that's enough doom and gloom and tales of failure. Promise I talk about the how and how we get things sorted and by whom. Well, you can draw parallels with the ongoing work about getting fluids perfect in hospitals with antimicrobial stewardship. We've had good successes in this. We've reduced healthcare-associated infections, and hopefully we can manage to build on that and preserve our antibiotic supply chain. We've done pretty well. And, we talk about the 4 Ds of IV antibiotics. Let's extrapolate those then to perhaps IV fluid therapy. So they are getting the right drug, getting the right dosing, getting the right duration, and even we talk about de-escalation as well. So there's an analogy there, isn't there? So that last bit, knowing when to stop, knowing if you should even start. That's a bit tricky with antimicrobials. Doctors, we have this very strong desire that we want to do something. We ought to seem to be doing something. We want to start antibiotics, and sometimes there's inflammation, but there is an infection, and we've got clever things that we can run these days. And procalcitonin, for example, has been used a huge amount in the last couple of years or so, especially in the COVID-19 epidemic. And that stops us from doing things. But of course, we sometimes want to do something, and perhaps we want to give some fluids. Maybe we shouldn't give fluids. Maybe actually patients don't need fluids. Maybe they need something else. Maybe they don't need fluids. Maybe actually they're just getting enough fluids. And maintenance fluids, of course, should only be for patients that are not eating and drinking. What if you've got hypotension with a patient that's actually meeting their fluid requirements perfectly adequately through their enteral routes? That hypotension should possibly be managed some other way. So it's about the right amount of the right fluid then at the right time. So, okay, I'll go back to they've had 4 litres of fluid and you get called as an expert and you say to them, well, just give us some more fluid. So, that's on that template there. Call an expert if you give them 2 liters of fluid. You're saying more fluids. Is just more fluids, really? Just straight off the bat? This is often misattributed to Albert Einstein, but it's pretty reasonable, isn't it? Just do the same thing again, you're going to consign yourself to failure. Other things. So quite often we realize that what we're seeing is distributary shock, isn't it? It's vasodilatation. We know the treatment for this is a vasoconstrictor, and we'd like an easy way to deliver that. So I apologize on behalf of myself and my colleagues once more if we are suggesting to give even more fluids. It is our fault. It also isn't. I'm going to go out on a bit of a limb here, maybe. I don't think I'm the only one to think this. Moving patients into intensive care is logistically burdensome for just a little bit of vasopressor. Some peripheral phenylephrine, even some peripheral noradrenaline. I hear your gasps. Or even a central line and proper pressors. Just to nudge that hypertensive patient's mean arterial pressure up by the 10 millimeters of mercury to make them pee adequately. Well, this was published a few years ago, canvassing views on what intensivists thought about how we can truly deliver comprehensive critical care. Critical care without walls. Well, levels 1 to 3 these days are well established in critical care, but many of the people who were surveyed didn't feel that they met today's standards. They've got some utility with respect to nursing staffing, but they don't really accurately reflect today's workload. The recognition of the benefit of higher levels of care of medical nursing input into high-risk post-operative care and to keep the ill medical patients now, it demands a sort of more nuanced, a more up-to-date approach. And you may have heard about this concept that's being bandied around a bit more, 1.5 care, something a bit more than ward care that's not full intensive care. Maybe we might manage fluid better in sick patients if we could offer something like this. It might actually mean less use of fluids. That might be the future. It may be we might be able to run a bit of pressors for people who need a bit of vasoconstriction. We may have an environment to do that. But let's talk about now. That's aspirational. Maybe that's the future. There's work to reconfigure. Let's see where that takes us. What about what we should do at the moment within current resource? How am I going to get patient care better? It's going to be through persuasion. And a good way of persuading people is education. Now, you're not just going to shout at people and tell them that they're doing things wrong, etc. You're going to have to genuinely understand processes, and I hope that you understand some of those today from the brilliant stuff you've heard from my colleagues. And it should ideally make them see and do things differently if you can pass on that learning to them. So let's take a step to educate everyone. Let's introduce something that you may not have heard of then, for example, that's really great. Some of you may or may not have heard about the ROSE principle, much promoted by a great chap called Manu Malbrain. It's a good mantra to think about all the aspects of IV fluid management. It's good to have at the heart of any educational piece and promotes thinking about the whole patient through their illness and their journey. So what's this ROSE thing? Well, it's resuscitation, optimization, stabilization, and evacuation or extraction. How does that work with the journey I talked about? Okay, so the R bit then. This is sort of patient rescue. This is the critically ill patient. This is fluid boluses, such as the 4 mils per kilo, aiming to correct their shock and achieve perfusion. Okay, and some of that may be associated with the use of pressors if fluids alone aren't enough. Then we've got organ rescue, fine-tuning, titrated to a specific endpoint, avoiding fluid overload, getting the sweet spot, address their needs, and then reassess them. Happens over a bit longer period. And then organ support, fine-tuning, conservative fluid management, ongoing support by fluid and electrolytes, addressing everything, measuring things and adjusting appropriately. But then right at the other end, we've got organ recovery, getting that negative fluid balance, that back to zero, goal-directed fluid removal. Ooh, now there's a concept for you. Extraction, venous extraction, back to that 0 point. Recovery diuresis, which you may have seen. Patient who suddenly announces to you that they're definitely better by peeing like a racehorse in the absence of us delivering some furosemide to them, or perhaps actually just us removing that fluid with some diuretics or using filtration to help them along the way. That's a good thing to think about so we can understand this journey for patients. When it comes to IV fluids, people need to understand their choices though as well. Well, first thing is do nothing. Do I actually need to give fluids? Of course, if they are able to eat and drink, then what about the enteral drink? It may be difficult for them. It may be as simple as giving them a straw for their glass, but making it easy for them, understanding why it is you're not meeting those requirements. What about, am I resuscitating or stabilizing and maintaining? And where am I on that balance? Well, the guidelines are clear. They say use a balanced fluid, one that meets electrolytic needs. For me, that's plasmolite. I replaced all our Hartmans as I thought this was a better fluid in my trust. It's got a bit better components to it. And the guidelines and standards also talk about dextrosaline with potassium, and this is a 12 hours requirement here as well. This is for the maintenance side of things as opposed to resuscitation. And there are now new fluids that have just what's stated, and they've even got a bit of magnesium too. So, there are choices rather than just sort of good old saline. What about those fluid choices though? How do we stop people using good old, bad old saline? And, you know, I have been known to refer to it as the devil's urine. Should be left for drugs dilution, for the treatment of overt hyponatremia, or where there is clear sodium loss, as I said, sort of gastric drainage and things like that. So, you need to change practice. You need to get away from that. You need to make it not quite so easy to go back to those old habits. This photo is from Hugh Davis in the Royal Glamorgan Hospital. And this is one way in which behaviour can be shaped. It shows how IV fluid is organised on the ward into maintenance, resuscitation and replacement fluid, so electrolytic replacements. It's a great example of how education and persuasion are being used to influence people to do the right thing, just by having fluids in the right boxes so that people are getting their fluids from what their choice is to do for the patient, not on what they think they should be doing. Actually, they're being led by the delivery process at the point in the ward. This targets both the nurses and the doctors to make good choices for their patients if fluids do need to be given. You can also change your prescription charts as well to both educate and shape behaviour. And this is Ashley's example from Shrewsbury. This pushes people towards full education and his full fluid guide. So QR codes as well, even on the fluid guide itself, on the prescription there to lead you to the fluid guide. So you can easily access stuff. So you're thinking about it at the point you're writing it up, just to check with your finger to go down, okay, what am I doing for resuscitation maintenance? This is what I should be doing, and these are the things I need to think about. So let's talk about all these people involved in the fluid process. Everyone involved has a part to play. The responsibility is shared. So many people engage with patients having intravenous fluids, they can all make sure it's okay. But you do need to have a champion. It works. You need somebody who's going to be able to direct this. There's somebody who needs to lead the way and coordinate. It can be a very rewarding role, and changing attitudes and seeing those benefits impact on patients and their outcomes is a great thing to see. So it's a good thing to do. It can really make a difference to how you feel about your patients and how you feel about yourself. So, each of the roles should feel empowered to intervene. Everyone should feel involved. So, consultants, be the IV fluid lead. Doesn't have to be a consultant. Help deliver fluids education. Review the reports on the fluids. Lead from above. Teach the junior doctors. The junior doctors really ideally should learn about fluid compositions. We need to really catch people early. We need to catch them as soon as they come to our trust, the hospital they work, when they rotate, so they can understand that when they come to your hospital, this is how we do things. Because this is what you've been missing elsewhere. This is where it is with electrolytes and what patients need and what we do about it. So, and also understand how fluid overload harms. Give them examples like I've given you and others have given you. Teach their peers, get them to do peer-led teaching, and also the next generation to teach medical students. And we really like junior doctors to undertake audit and quality improvement cycles, so get them involved in small, manageable cycles to be able to do stuff. But nurses too, we can educate nurses and we can get the nurses to educate their peers to promote good practice at a ward level, to undertake quality improvement at a ward level, but also to report poor practice, to speak up and check what's right for the patient. We know that nurses like to say that they are the patient's advocate, and indeed they are, so they should feel empowered to speak up and say, look, this is not right for the patient, to challenge the doctors, say, I don't think this is something that you're doing right, and to steer our behaviour as doctors as well, what we should do for them properly. And pharmacists as well, to educate the pharmacists, to get the pharmacists to educate each other and to promote good practice. They scrutinise the drug charts. They scrutinise the prescriptions. I gave the Parkinson's paracetamol example. They're there to help promote good practice and prevent errors and risks. They too can report poor practice to us and to undertake quality improvement to make sure that the fluids are used appropriately and to treat them as the drugs that they are. Making these changes all lends itself very well to a full quality improvement methodology. You should be able to get buy-in from your QAI leads at your hospital because actually the plan, do, check, act, the PDSA, all the different things, decoder, etc. that you use work very well for this. You should be able to get them to support if you're into a properly led quality improvement project. And if that's not enough to persuade them, you really want help, then you can look and see about some of the other successes around, and you can go straight to the top of the food chain. This slide is taken from work from Marcia McDougall in Fife, who is the champion of fluid champions. We'd be pleased that the overall fluid use had dropped dramatically over the time period, nearly a decade, looked at from 0.65 to 0.35 litres per bed day. But I suspect your chief executive or your chief financial officer's eyes will be drawn to the not insubstantial cost savings to be made by getting it right. £98,000 less per year, okay, over about a decade. If you want a business case to empower your plans, then these are examples that you can use. And actually, she gives examples about switching that elicited about £19,000 just by changing from 500-litre bags and getting the consequences of those right. We are all in this together. Everyone in the multidisciplinary team can make a difference. As I've said, doctors of all grades, nurses and pharmacists. The reasons should be pretty clear, from physiological reasons, from the research that supports what happens when you get it right and what happens when you get it wrong, how we can stop patients becoming edematous and how we can stop them having to try and undertake the physiotherapy and rehabilitation after critical illness. That means that they've got another 10 kilos on each limb that's just edema. So they're starting lifting weights before you even actually ask them to lift weights to try and get over their critical illness, neuromyopathy and sarcopenia. We can make a difference by getting these things right, by getting the prescription right, and making sure that we follow the rose bit for our journey. Keep an eye on those fluid balancers, and also keep an eye on those electrolyte balancers. And if we don't have systems in place to be able to do it, we should be complaining. We should be asking for them. If we don't have daily chlorides, let's see if we can get those things done. If we don't have regular weights, so that we can work out whether or not those changes actually represent them just having changes in their muscle bulk or fat bulk, and they're actually just fluid. If you're not really sure, let's try and get our patients weighed and put it all together so that we can follow those clinical guidelines, so that we can meet those standards, so that we can measure things, we can make changes, we can improve them and remeasure them and make a difference to what happens to all of our patients, no matter who we are in the hospital. I chose the Turning the Tide theme for this, but of course I've got switching from saline for this. But I hope by the end of this evening, you won't feel futility like the testing of autocracy by King Canute, but rather a sense of empowerment, that you know why things should change and what happens if they don't, and how you might be the one to change it for the benefit of all. Thank you very much.